I think, let's see if everybody's gotten into from the waiting room into our main room. I'm Rabbi Jessica Graf, Senior Rabbi at Congregation Sheriff Israel, and I want to thank you all so much for joining us for our From the Front Lines conversation with our two esteemed doctors, one of whom I know quite well, Dr. Jonathan Graf, and one who I've just met, and we're so grateful to Dr. Sarah Doernberg for joining us today in conversation with John. This series started, and many of you that I'm seeing on the screen are insiders here at Sheriff Israel. I know this program is open also to people who are joining us from all over the place, friends and relatives who are interested in learning more about COVID and where we're at this moment. The From the Frontline series on COVID started at the beginning of this pandemic when it felt like things were swirling out of control and we didn't have any place to get really good information. So we kind of dove in internally to ask our local doctors and trusted advisors what this was all about. And I feel like though this has been going on for so long, in some ways, we are at a little bit of that kind of place with Omicron and the confusion and lack of clarity about what's going on. So today we have an opportunity to really discuss the current moment and hopefully to be really enlightened, feeling a lot stronger with this information to be able to combat whatever remains out there until the end of this pandemic, or at least for the current moment. So thank you all for joining us very much. If you've submitted questions to Peter Bonos, they have been forwarded to our doctors and will be addressed during this time. So without further ado, I want to introduce Dr. Jonathan Graf.
And thank you very much, Rabbi Jessica. Of course, as you know, Jessica is my wife, so it's always a pleasure to be able to do anything during the day. It's semi-work related, but also get a chance to do it with my wife as well. Welcome, everyone. It's a pleasure to see so many of you familiar faces out there, the 80 computers so far that have logged on, probably 100 of you. I want to introduce all of you today to a really special colleague of mine, Dr. Sarah Dorenberg, who is an infectious disease expert at the University of California, San Francisco, and a fellow associate professor of mine. Dr. Dorenberg is not only a terrific clinician, but has had an academic interest primarily in antimicrobial or antibiotic stewardship in our healthcare system and how it relates to hospital-acquired infections and bacterial resistance. But in the era of COVID, she has had to pivot, as have we all, into other areas as well. And Sarah is the principal investigator, one of the principal investigators on several key pivotal clinical trials that have been ongoing at UCSF for novel therapeutics and treatment strategies for patients who are sick with COVID-19. So Dr. Dorenberg is a particularly, I think, excellent choice to be our guest today to help talk about a lot of the issues and confusion that I think has sort of surrounded the latest pandemic surge with the Omicron variant. And so, Dr. Dorenberg, it's a pleasure to welcome you here today. Again, I have to say that for those, I mentioned one last thing. Dr. Dorenberg has also been tasked, and correct me if I'm wrong, there are several novel therapeutics that have come out recently to help both prophylax and treat patients with COVID-19. And many of these are in very, very short supply, but Dr. Dorenberg has been tasked with navigating the confusing data from the clinical trials, recommendations from the CDC, from the FDA, sometimes all of which appear to conflict with one another, and to balance that with the limited resources available here in San Francisco, and in particular at UCSF Medical Center, and to come up with guidelines by which we are all following in order to use these therapeutics in practice, because they need to be distributed equitably and effectively to the patients who need it the most. And Dr. Dorenberg has sort of been at the forefront of that. So with that, Dr. Dorenberg, welcome to our program today. I have to say, it really is a pleasure to see you. And from our days at the General all the way till now, it's been great to see your career evolve over the past decade and more. And welcome to the program.
Thanks so much for the very kind introduction. And Now you made me feel old, but thanks for having me.
You're welcome. I think all of us who've had kids in the last decade, by definition, have aged, I think, significantly, let alone during the pandemic. So let's just start with a little overview about the Omicron variant. I think the first question I sort of want to throw out there, sort of as a broad stroke, is what makes the Omicron variant different than all these other variants that we've been subjected to over the past 2 years? What is it about the novel mutations and such, and the spike protein and others, that makes this particular variant so different now than what we were dealing with other variants 6 months ago?
Yeah, there are really two main things, without getting into kind of the molecular biology too much, two main clinical features that we're seeing. One is that it is much more infectious than the other variants that we saw. So we're just seeing, very rapid spread in situations where we weren't seeing it previously. And then the other is that it is doing something called immune escape, where it is evading some of the protection that we've developed over the past couple of years in the form of vaccines and natural immunity from people who have gotten infected before, and is also able to escape some of the therapies that we had developed, namely some of the monoclonal antibodies that we had been using pretty widely for outpatient treatment. I think one of the good news about Omicron, at least thus far, is that it seems to be causing less severe infections. So while we are seeing many more patients getting infected, the severity of illness is lower. The number of patients who are requiring ICU level care is lower. And I think that is maybe a silver lining of this otherwise very aggressive variant.
I think what's remarkable to me, at least what I'm seeing at the General, when I was on the medicine wards as an attending physician, a little less than 4 weeks ago, we had, I think, 1 or 2 COVID positive patients in the hospital. We now have 42. And 8 or 9 of them are, admitted with COVID as opposed to admitted for COVID. But a lot of patients are admitted for COVID right now. And I just think, what strikes me is that the number of people infected is so large that the surge that we're seeing in the hospitals, there still are a lot of sick people with COVID-19. I think there's this impression out there that because Omicron is mild, that everybody's walking around with a cold. And I think, there's no question in my mind that had this been the original variant 2 years ago, and had society remained open as we are now, we would have hundreds, if not maybe 1,000 patients in the hospital had it been equally as virulent as the original strains of COVID were. But as it stands, even though it's less virulent, it's so infectious. It seems like the hospital is swelling here. Is the same true at Parnassus as well?
Absolutely. We went from somewhere in the tens or low teens to having, I haven't checked in this afternoon, but each time I check, it goes up by 10, somewhere on the order of 80 patients. There's been a lot written recently about being admitted for COVID or with COVID, meaning patients who are admitted, with a broken leg who happen to test positive because there are so many people out there with the virus. I think that making that distinction is really challenging, because one of the things that I've noticed is there's a lot of people who have maybe underlying medical conditions that have gotten just destabilized from having COVID. So they may get admitted with the diabetes flare, or, and a very elderly patient admitted with confusion, but it has COVID, and COVID may be contributing to some extent. I think what we're seeing less of is the severe pneumonia that we had seen during, the Delta variant and other variants, where patients come in with low oxygen levels and need a lot of oxygen support and need intubation. We're still seeing some of those, but that is less frequent than what we're seeing in the hospital. But certainly many patients with COVID admitted currently.
Yeah, it's interesting. There are these early studies that suggest as well that maybe the Omicron variant has a tremendous ability to infect the upper airway with much lower viral titers and much more infectivity and to be spread, obviously, but less ability to infect the lower area of the respiratory tract. Has that continued to bear itself out from the stuff that like I initially saw a few weeks ago, or?
I think so far that's been what most of the data has shown, is that it seems to be less tropic or causing less infection in the lungs. But nothing's 100%. The viruses don't always read textbooks, so this is just kind of patterns that we're seeing, but definitely seems to be what we're seeing today. That may change tomorrow, like everything with the pandemic, things change quickly.
So does the 6-foot rule still apply? And as our standard masks good enough? With Omicron, it just seems like it's almost like measles. You wouldn't walk into a room with somebody who had measles with a simple mask on, or stand 7 feet away from somebody with measles. You'd be like, that's really transmissible. I need to take other measures, necessary. Is it the same with Omicron? And should we be thinking about masking our kids with something more than a simple? I mean, my 5-year-old son chews through his cloth mask almost every day. We have to get him a new mask because one of the 2 layers has a tooth bite mark, through the middle of it. So are there other things that we should be doing now? How should we be thinking about the transmissibility of this variant versus other ones?
I'm glad to hear other people's children are doing that. My 7-year-old does the same thing. She'll come back with like spaghetti inside of her mask. Yes. I mean, I think I would say we've learned a lot about how to mitigate and prevent COVID throughout the pandemic. So there is not a kind of one size fits all approach. And I think we need to really up our game with regards to all of the measures that we know how to take. So increasing ventilation. I'm a big fan of being outside with my family. We're outside most of the time when it's not raining, because I think it's a safe place to be, and it's a place where I'm comfortable not masking most of the time when I'm out with my kids. Wearing good masks is important when you're inside in crowds. So I agree, cloth masks are going to be much less effective, especially during this variant. There are a lot of resources out there about types of masks. You can now get N95s, KN95s, KF94s, which are these masks that really are very effective at filtering out the virus online pretty easily. You have to be careful not to get counterfeit ones, because unfortunately that's a problem. But there are resources that can help to guide you to getting ones that aren't counterfeit. The thing with masks that I would say is you really have to make sure there's a good fit. So if you have a really high quality mask and there's like a big gaping hole out the nose, that's gonna defeat the whole purpose. The whole purpose is to really fit very firmly to your face. Most of the ones that are effective will tie around the back of your head. So that's one clue that you might not have a good enough fit if you have the behind the ear ones. There are some things you can do to adapt those. I try to assess my daughter. In the hospital, we do these fit testing where you go under a hood and they put this stuff in that you can taste if your mask doesn't fit properly. And, not everyone in the world is going to be able to get fit tested, but you should have a really tight, kind of snug fit to your face. I test with my 7-year-old who wears glasses. I can check to see if she's fogging up her glasses. She shouldn't be if there's a good fit. So that's one way that I assess. And then, besides ventilation and masking, you asked about 6 feet. So I think it's a matter of time and space. It is not that if you're 3 feet versus 6 feet versus 9 feet, that your risk is going to change greatly. It's a matter of how close and for how long, and what other measures are in place as far as ventilation, masking, et cetera, vaccination, and all of those factors kind of play a role. So, if you are in close setting with people, then having good masking and good ventilation is even more important. If you're far away and there's excellent ventilation, your mask may not be quite as critical as those other situations.
So, I mean, I think the question always comes up with in gatherings. So here, obviously, at the synagogue, they're trying to decide, is it safe to have services? If so, how many? What kind of meetings can they have indoors? What kind of masking? What kind of vaccination? Ditto for the schools, obviously, that our kids are in, that seem to have a different kid every day coming in with COVID. It seems like, or being found to have COVID and being sent home. I think an analogy I've always tried to use for people is that there's no yes, no, on, off. It's like sunscreen. If you wear SPF 2, and you go out in the sun for 10 minutes, right? And you're like my skin complexion, you'll get burned. If you put on 50, I could probably go out for, an hour or two. But if I stay out for 10 hours, I'll eventually get burned. It's total cumulative exposure and the degree of protection you have. It's exactly what you're describing. And I think that's true for masking. It's true for vaccination. If you're vaccinated, but you sit in front of somebody who's blowing COVID in your face for 12 hours, you'll probably get COVID. If you're just having a chance encounter here or there with people who have COVID, you're probably better protected than somebody who's not vaccinated. So I love how you explain that and how it resonates in almost everything that we do to sort of live with Omicron right now.
I'm going to steal that sunscreen analogy. I like it a lot. The other thing I'll add is that, we're living in a time where there's risk and people have different thresholds of what risk they're comfortable with. And so I do think it's important just to understand that and to know that there's probably no way to make it a zero risk of exposure to COVID right now. And so kind of understanding that and learning to live with it and balancing other factors that are equally important, like education of our children and mental health and other things, I think are really important that we take those into account. I mean, one thing that I like to remind myself of is, many of us get into our cars every day and drive to where we work without really thinking about the fact that we're taking a risk doing that. And this may need to become something like that, where there is some risk to it that we, need to balance with some of the other factors in our lives.
Oh yeah, we were very quick. We're a very outdoorsy family as well. We've done, Jessica can, I'm sure, can confirm this. We try to do almost everything we can outdoors, but we were the first to send our kids back to school the minute we were able to get them back. We're like,
yeah.
Whoa, it's for your health and our health. You need to go and get out of the house. So
yeah, one of the parents at my school came up to me the other day and she said, "Oh, good, I'm so glad to see you're here." And I was like, "Oh yeah, if school's in session, my kids are going to be here. They're definitely going to school right now." They are fully vaccinated. They wear KN95s. They wash their hands, but they are definitely in school.
Oh, that's great. So I hope that gives everybody a lot of confidence out there. And so I guess we've talked a little bit about the severity of disease being less overall in people with Omicron. Can you speak a little bit to patients who are immunocompromised and other patients at high risk? Are we seeing those patients, even those patients who may or may not be vaccinated, at risk? And are 2 vaccinations considered enough anymore, or is Omicron really a 3 vaccination type of bug? And I'll follow that up with just some of my own personal biases about the concept of boosting versus primary immunizations.
Yeah, and you may be better in the immunology world to answer some of those questions, but I do, as my clinical interest and job is taking care of patients who have transplants and are immunocompromised. And throughout the pandemic, it's been very challenging for that group of patients because they are at higher risk for infection and for severe infections, and then unfortunately don't respond as well to the vaccinations that we have. And there are certain groups of patients that don't mount a response as you would with someone who has a fully intact immune system. There are some things that we've learned along the way. Some of the patients who didn't respond to the first 2 doses do respond to a 3rd dose. And in fact, for patients who are severely immunocompromised, it's now recommended as part of their primary series of vaccinations that they receive 3 doses. That's considered the primary series, the way you would get 3 doses of measles, mumps, and rubella vaccine for immunocompromised patients. And then what we are seeing during the time of Omicron is that we really are needing boosters, that our immune responses have seemed to wane a little bit with kind of the traditional either 2-dose vaccine or 3-dose series, depending on your immune status when you got them. I will say that even having received that is a really good protection against hospitalization and death still. So having had a vaccine series is really protective. But definitely having a booster does improve that protection. And the last thing I'll mention is that for those patients who are severely immunocompromised, who got that 3-dose series, and the way that was rolled out was confusing because at first it was 2 doses and then they realized you needed a 3rd dose and kind of plugged it on. Those patients are actually eligible for a booster, which is a 4th dose of vaccine that should be given 5 months after completing that 3-month series. And I think that that message hasn't gone out there very well, but for anyone who is immunocompromised, that 4th dose is now recommended. So something just to be aware of.
So that's great. So that's beautifully explained. I haven't, it's funny, we've had a lot of these talks and you've probably explained it better than anybody else. And I'm going to summarize it, I think, for people out here. The difference between, it's the difference between, in my mind, primary immunization versus boosting is, whether you get the shots up front or later as your immunity wanes. I look at it sort of a peak and valley type of phenomenon. When the initial Pfizer and Moderna vaccines were approved, they were approved as a 2-shot regimen against a completely different variant with a sort of different set of goalposts that everybody was trying to study. And I think in the era of Omicron, and what was not looked at was whether or not 3 shots or 4 shots or 5 shots or whatever the primary initial regimen would be for the other variants, let alone in the current environment of Omicron. And I think the message out there is that if you have a compromised immune system in which you're not expected to mount the largest response to 2 doses, 3 doses is better than 2. You mount a higher titer response, and the diversity and specificity of that immune response for COVID, and in particular one that would be effective against the Omicron variant, is better if you get 3 shots up front instead of 2. So a lot of people call it boosting. It isn't. It's really a primary series of injections. It's just that the initial phase 2 series of shots that is formally FDA approved for the Pfizer vaccine is actually not adequate for people who have compromised immune systems for whatever reason in the era of Omicron. And I'm so glad that you explained that. And then a booster is something that you do further down the road, like we do for tetanus and for other vaccines, where immunity naturally wanes over time. We're not expected to have highly effective immune responses against pathogens that have been cleared from our body. It's not healthy. Our immune system has to be reset back to normal and be prepared to respond against other infections. Otherwise, bad things can happen to chronically stimulated people with chronically stimulated immune systems. And so our immune system naturally wanes, and that's a good thing. But in an era of COVID, where variants are reappearing all the time and escaping our immune systems, it's sometimes the ability for our immune system to sort of turn itself back on again is not fast enough for variants like Omicron that are able to get in and infect people so quickly. And so by boosting people, we can raise their immune responses back up again after they've naturally waned. So that's really the difference between a primary immune response for everybody and sort of this concept of boosting. And I love how you frame that, Sarah. And I think that's great. So there are different ways people can be immunocompromised. They can be on medicines, right? They can be transplant patients. They can have natural immune system problems. What about for patients who are at really high risk for severe outcomes from COVID? Patients who are obese or older or have diabetes or other comorbidities. Boosting, obviously, very, very important for them. How about getting 3 shots as a primary series potentially, or what about mixing and matching vaccines for the primary series and the booster? What do we know about that?
Yeah, data is still emerging. I think the mRNA vaccines are really fantastic, and any mRNA vaccine you get will be good. There is some data to suggest that the Moderna vaccine is slightly better than the Pfizer one, and that mixing and matching may have some benefits, but I got Pfizer for all my vaccines. It was what I was assigned when I got it, and I am not worried that I didn't get enough. I think those vaccines are really excellent. I think there is more data to suggest that the J&J vaccine is not quite as good, and I would recommend that people who had the J&J vaccine go seek out an mRNA vaccine for their booster. That will boost up the dose. As far as like making an initial series more shots for an immunocompetent patient who's at high risk for complications, I'm not aware of recommendations or data to support that at the current time. So I would say, making sure you're fully vaccinated and boosted when that time comes is really important. And then there are some therapies that have emerged that can be given if you were to get COVID to help to prevent those complications.
Yeah, I'm living proof that the Pfizer vaccine absolutely works. my person who shares my bedroom with me got COVID earlier this year, and I didn't. And so or if I did, it wasn't detectable by the current laboratory techniques that we have right now. So the vaccines are spectacular. The mRNA vaccines are truly breakthrough technologies that are absolutely spectacular. And so I'm with you on that one. Everybody who's been vaccinated with J&J should go and get boosted with one of the mRNA vaccines. There's no question about it. So let's talk a little bit about testing, and then we'll talk a little bit about some of these emerging treatments and prophylactics for COVID. We've gotten a ton of questions now in just the last few hours about testing, and there's a lot of confusion here. I do a lot of PCR in my own lab. For those of you out there, I don't know, I have my own lab over here, and PCR has always vexed me for a lot of reasons. But it's obviously now in the clinical vernacular, and I think a lot of people are having confusion over the CDC guidelines about testing, about quarantining. Do you quarantine if you're sick? Do you quarantine for 5 days and retest or not retest? Do you, if a PCR test is positive, are you still infectious or not? Of course, we know the answer is not necessarily, but can you explain this for people out there and explain the difference between antigen tests and PCR tests, and whether or not testing is a good thing to do, both for screening, family members coming over to home or going to school, or screening to get out of quarantine?
Yeah. Yes, there has been much confusion. So I will say there are two main types of tests to detect active COVID infection. One is designed to detect the genetic material of the virus. The most common version of this is a PCR or a polymerase chain reaction. There are some variations with other names that are acronyms I won't get into. The benefit of those are that they're very sensitive, meaning like if there's a tiny amount of virus around, you can usually detect it. So it's good if you really need to be sure that someone has an infection or not. So for situations like someone's about to have a procedure that will cause aerosols to go everywhere, it's good to know for sure if they have an infection. Or for a patient who's at really high risk for complications and you really want to know if they need treatment, you may want to, at least get that for a confirmatory test. The other type of test is called an antigen test, which detects the proteins that the virus makes. These tests are the ones that are faster. They're the ones that you can get over the counter, though there are some you can get in the hospital or clinics as well. And they're really good for telling us if someone is infectious. So they are less sensitive, meaning if you have a little bit of the virus around, they may not pick it up. But they're pretty good at picking up people who are very infectious, who have a lot of virus around. So with that premise, you can kind of figure out when to use which test. The other complicating thing right now is that PCRs and really all tests are very hard to come by. So for someone who has symptoms, I would say get tested with any test you can access in an amount of time that will be actionable. So, they had us check tests when everyone came back from the holidays. Those are coming back in 4 days. It's not that helpful to know that 4 days ago you were infected or not. It's more helpful to know today. So if a test you can get gets you an answer quickly, I think that's the test you should take. And then, there is a lot of conflicting information out there about whether or not to test at the end for someone who was infected at the end of the period of having an infection. It is not a requirement currently that, once you've had an infection, as long as you don't have symptoms, just haven't had a fever, the CDC guidance for patients whose immune systems are intact is that they can come out of that isolation period after 5 days. In certain settings, like the healthcare setting, we are setting a higher bar to make sure that there's not spread of infection. So for instance, here people would get a test with an antigen at the end of that 5-day period. And really the logic behind this 5-day shortening of the period of isolation is based on a couple of things. One is that throughout the entire pandemic, we've known that the viral loads really peak very early on in infection, and in most patients go to undetectable within a few days. 5 days in the vast majority, 10 days in almost 100% of people, except for severely immunocompromised people. The 10 days was kind of in an abundance of caution to make sure we capture absolutely everyone. Because Omicron's a little bit different, it seems to be setting on more quickly and off more quickly. That kind of gave some rationale to shortening the duration of the isolation period. But the antigen test can be kind of one more way to just be absolutely sure that you're not infectious at the end of that period for someone who wants to know or needs to know because they're going into a higher risk setting or going to be around people who may be more susceptible. I will note that the CDC guidance still does recommend for that full 10-day period that you really wear very effective masks. So it's not that those second 5 days are zero risk of transmission. It's just very, very low that someone whose immune system works well is going to still be carrying infectious virus at that point.
Yeah, it's interesting. My experience going back, now almost 2 years, when I first started seeing patients getting COVID who were immunocompromised, was that they were remaining, even their PCR test, which I knew didn't necessarily reflect their infectiousness, were remaining still positive for awfully long periods of time, months on end. And it just made sense to me that, this is a little technical, I guess, for people out there, but RNA, which is the genetic material of this virus, is remarkably sensitive to being degraded in the environment, on your hands. You have enzymes on your hands that can degrade RNA in seconds. Again, as I can attest to personally in my own lab from all my failed experiments. That's one reason why. But so it made sense. And I ended up sending a lot of these patient samples to the state lab for actual viral culture that ended up being positive. So I think it is important to note that for immunocompromised people, that they can sometimes remain positive for a while. And that's now been confirmed with these antigen tests. I've had patients now testing themselves, past the 5-day quarantine, and a lot of them are still positive, who are on various medicines. And I'll also, by the way, vouch for another fact that you said. I've had several patients on very potent immunosuppressive medicines, like ones that theoretically not only suppress the immune system, but could teach it to become resistant to vaccines and stuff, and what we call anergy. And in fact, and after 2 doses of an mRNA vaccine have been negative, but with the 3rd dose given have almost universally turned positive. And so I'm very, and patients on B-cell depleting therapies and things like that. So everything that you said so far is, I think, jive very well with my own personal experience in my patients. So this is excellent. Let's move on a little bit in the last few minutes into therapies. This is an area I know is near and dear to your heart and a lot of our hearts here. You've led a lot of these clinical trials and are leading a lot of these clinical trials right now at UCSF to study a lot of these new medicines. Let's talk first about some of the newer antivirals. When I say newer, it's sort of always in quotations because they're newer, but they're not as new as Omicron, which is really new. So let me ask a couple of questions about this. There are some new therapeutics that have come out, some of which appear to retain significant efficacy against Omicron, and several that do not. Can you speak a little bit to some of these? There's Paxlovid, which is an oral drug that people can take at home. And who is eligible to get Paxlovid, and what are some of the issues with Paxlovid? It seems like a pill that you could take at home for 5 days is an incredible advance in the era of COVID-19. And then there's the Merck drug molnupiravir and some antibodies like sotrovimab, that all of which appear to have some activity against Omicron. Can you speak to some of these therapeutics? Who's eligible to get them? How do you get them? And when should people seek medical care? If they're isolating in their own home, when should they tell their doctor? And they did their own home test and they're positive. Should they tell their doctor, and when should they be considered for these treatments?
Yeah, it's an exciting time, and it's also quite complicated because we have these drugs now available, but we don't have enough of them nationwide to treat all the people who may stand to benefit. So there are now 4 drugs that are available and active against Omicron for patients with mild to moderate COVID who are at risk for progression to more severe disease. So I'll break that down a little bit. Mild to moderate COVID means either an upper respiratory tract infection, like a cold symptoms without having involvement of the lungs, or involvement of the lungs without causing the oxygen level to drop. So these tend to be patients who are in the outpatient setting, who have mild to moderate infections. And then what do I mean by high risk to progression? There's a list that we've learned throughout the pandemic of factors that contribute to risk of progression. And when I say progression, what I mean is progression to needing hospitalization or needing to be on a breathing machine or getting a life-threatening infection. Some of the factors that are important that we consider are age. So we know that most of the deaths are occurring in patients over 65 years of age. So that's a really important factor to consider. Comorbid conditions like having diabetes, heart disease, kidney disease, things like that. And then I think we've talked a lot about immunocompromise. That's a really important one. And comorbid conditions are not like a yes/no thing. It's what we found is that they're really additive. So, someone who has 5 comorbid conditions is going to be at higher risk than someone with just 1. So that's another factor.
Years old is more at risk than somebody who's 65. We have a specific question about what is being 75. How much more risk does that place you for severe COVID?
Yeah, it's a great question because it's not like you turn 75 and your risk goes from one to another. It's going to be a graded risk, and a lot of it depends on your comorbid conditions, your immune status, and other things. But some of the cutoffs that are used are over 65 or over 75 because studies have shown kind of increased risk with those age groups. The other factors that are important to consider are vaccination status. So people who are not vaccinated, who didn't respond to their vaccine, are at much higher risk for progression. And then there are unfortunately demographic factors that we've learned about or have been really laid bare by the pandemic that also play a role. So all of those things take into account kind of place someone at higher risk for progression. And those are the people who are eligible for these treatments and who stand to benefit. And then, I mentioned when we were talking about testing, how quickly the onset and offset of the viral loads go. These antivirals work on actively developing virus. They work to inhibit some of the enzymes that the virus uses to kind of package itself up and get itself out of the cell or get itself ready to be packaged up. And they won't work if the virus is not doing that. And so really they're effective only within the first 5 days of symptoms. So someone who is at high risk for progression, first 5 days of symptoms, mild to moderate infection, that's the group that really should be getting these outpatient treatments. And then there's 4 of them that are available now. 2 of them are injectable and 2 of them are oral pills. So the injectable options are a monoclonal antibody that really binds to the receptor of the virus and prevents it from binding to the cells. The one that's still active against Omicron is called sotrovimab. And unfortunately, the supplies are extraordinarily constrained of that agent. It's a one-time administration at an infusion center. So some of the considerations are, not everyone can get to an infusion center to access this treatment. And then there are some allergic reactions that happen, but they're usually pretty uncommon. The second injectable option has been pretty newly described, and this is an antiviral called remdesivir that we've been using in the inpatient setting quite a bit for our patients. But there recently was a study published that showed that in outpatients who got a really short course of 3 days of treatment, that prevented patients from needing to go to the hospital or having kind of worse outcomes. As you can imagine, that's incredibly logistically challenging to pull off giving someone 3 days of IV therapy when they're highly infectious, but is an option available at some places. Many centers, including UCSF, are working to try to get that going, but it's been complicated, and especially with staffing issues in the home care companies, that's kind of been another barrier. The two oral agents are very exciting. You've probably heard a lot about them. The first one is called, it's actually a combination pill of nirmatrelvir and ritonavir, easier said as Paxlovid, which is its brand name. This is a drug that's really effective. It decreases the chances of hospitalization really significantly, and is very promising. It's a 5-day treatment course that needs to be given early on. And the main issue with this medication is that it interacts with a lot of other medications that our patients get. Like pretty much every class of medication that you can imagine has an interaction with this drug, and some of them are quite severe. And so it's complicated, and a lot of patients and doctors need to be aware that if they are going to use this drug, they need to check really carefully through the list of medications to make sure it's safe to give. That drug, unfortunately, is very hard to make. So though they are trying to ramp up production, it's not going to really be ramped up to a degree that will be able to have easy access for a couple of more months. So we're getting supplies, but in very, very limited supply. The last drug that's a pill is called molnupiravir, which is kind of the one of the four that is the least effective. So in its study, it was much less effective at treating patients, though there was still some benefit seen. And the main downside of this is that it can lead to problems with fetuses and developing bones and cartilage, and has some mutagenicity potential. So it's only approved for patients over 18. It is not approved in pregnancy or patients who are lactating, and for anyone who is either a partner of someone who can get pregnant or who can get pregnant themselves, there are specific recommendations for contraception use. So that is kind of the complex issue around molnupiravir. That drug is actually in much better supply, so easy to get, less effective. So how we work through all of this is really challenging because, when a patient comes to you, you don't know if the pharmacy has the drug or not. There's only a handful of pharmacies that are actually receiving these drugs. They're running out quickly. Trying to access that information can be quite challenging. And so the NIH has developed some guidelines of how to prioritize patients based on risk for progression for which treatments they get. We've modified those to some degree. I think other centers have done the same, to develop a system that is equitable, that will really be able to get treatments to as many patients as we can who can benefit from them. My hope is that this complexity will go away as we get further through the pandemic and get some more supplies. But I think the next few weeks are going to be really, really challenging.
Yeah, I can vouch for that as well. We have 5. So the course of Paxlovid, for example, is a 5-day course. So we had 5-day courses of the drug available in the city health system to begin this week. I used 2 of them on patients, and I can tell you it takes hours to prescribe these because you have to go through the drug-drug interactions, and something as simple as people's cholesterol medicine interacts with Paxlovid. So you have to make sure all the drugs are stopped and given safely, and then to actually acquire the medicine is a whole nother thing. And then it has to be delivered and started within 5 days in order in Paxlovid's circumstance. So most people don't find out that they're positive until their 3rd or 4th day of symptoms. So already the clock is ticking. It's really a dramatic effort to just sort of paint this vivid picture for people out there to get these medicines and get them to people, which is why if you develop symptoms, you should test yourself right away. And if you're in this sort of Goldilocks kind of range that Dr. Dorenberg described, where you're not sick enough, but you are in a risk category that could make you sick at a higher risk of being sick, then you are technically qualified to get some of these difficult to get therapies, and you should at least present yourself or make yourself aware to your physician so that you can be referred for further consultation about whether or not these treatments will work for you. And again, there's a time-specific limitation on when they can be given. Paxlovid is 5 days. I think sotrovimab is up to 10 days, I think, although the earlier always the better. So, and I know in terms of sotrovimab, which I've also tried to get, we were promised a shipment to the city earlier this week, it never came from the government. And so we're still waiting for our weekly shipment. We don't have any right now in stock. So we're actually rationing. We're actually rationing therapeutics and care right now in the US, if you can believe it. But that's the reality of the situation we're in. I don't know. I guess Parnassus has a few doses here or there as well. So again, I encourage everybody to present to their physicians and allow us to sort out all these complexities. Quick question about prophylaxis. So there are people out there who either aren't vaccinated or didn't get a great response to their vaccination or are otherwise immunocompromised. There are potential drugs out there that can lower the risk for both acquiring and COVID and having severe COVID manifestations. Can you speak a little bit to Evusheld and who qualifies for that and how they can go about how it's given and how patients can avail themselves of that if they need to?
Sure. Yeah, so Evusheld, which is another monoclonal antibody, it's actually a combination of two, tixagevimab and ciljavimab. They make these hard to pronounce, so that we'll use the brand name, I think, is a monoclonal antibody that is really long acting that has been approved for prevention before exposure to COVID. So these are for patients who are at risk for complications from COVID, but who have not yet been exposed to someone with COVID. This is actually, it's interesting, this drug was studied in patients who have some of those risk factors that I talked about for progression, but it's approved very specifically for patients who were unlikely to respond to vaccines, so severely immunocompromised patients like those with transplants or those with hematologic malignancies undergoing treatments, or some of those B-cell depleting agents that Jonathan was talking about that really knock out the entire immune system. So very severely immunocompromised patients are kind of one group that would be eligible. And the other group are those who are medically unable to get a vaccine. So they are very specific in the FDA guidance. It's people who are unable to because of an allergy or some other medical condition. These are not meant to replace vaccines. They're meant to really be in addition to giving vaccine, at least for those immunocompromised patients. For these patients, it's 2 shots at one time, given that's supposed to last for about 6 months. It's something, if you think that you're severely immunocompromised and may meet criteria to discuss with your doctor, it is kind of an extra layer of protection. In this study that looked at pre-exposure prophylaxis, it did decrease infections. I think it was around, the placebo group had around 1% of the patients got infected in the 6 months after receiving the placebo versus something like 0.2% in the active treatment group. This was before Omicron. I'm sure those percentages are much higher probably in both groups. But it is another exciting treatment. I think especially, we have some immunocompromised patients who are also healthcare workers or teachers or in other professions where they really are at risk for being exposed. And it's been another kind of tool that we can provide them to help give some protection.
That's great. We have a lot of members, several members like I know of personally in the community who have hematologic malignancies, multiple myelomas on treatment, patients who, people who couldn't tolerate the vaccine, they had adverse reactions to the vaccine when they tried, and therefore weren't able to complete the full course, who are exposed in the healthcare setting as well to people all the time, I think, who would be very eligible for this type of treatment. I liken it, when I explain to people, I liken it almost to the passive transfer of antibodies that go from mother to fetus, sort of protect the fetus for the first 6 months of life once they're outside the womb. They still have the maternal antibodies circulating around. If you are unable to mount an immune response or have antibodies to vaccination or otherwise immunocompromised, this is sort of a passive immunization. You can be given the antibodies that will hang around for several months and hopefully help add an extra layer of protection against severe COVID disease. So thank you for explaining that. That's an option. And I know we don't have it at San Francisco General, but we are sending patients to UCSF through a consult link, and I have patients who've been able to get it as well. And so everybody should avail, who are eligible should try to avail themselves of this as well. So thank you.
Yeah, I will say also, like everything else right now, in somewhat limited supply, though I think the supplies of Evusheld are a little bit better than of the monoclonal antibody that's approved for treatment. And then the other thing I'll mention is you may have heard that there were some antibodies that were approved for prevention of COVID after exposure to COVID or post-exposure prophylaxis.
Yes.
We were really excited about those. Unfortunately, the ones that are approved for that indication are not active against the Omicron variant. So we've actually stopped offering those. Most centers are no longer offering those treatments, but maybe in the future that will become an option.
That was going to be one of our collaborations too that got sort of torpedoed. We had a clinical trial ready to go looking at post-exposure prophylaxis. And then lo and behold, Omicron came out, and the Regeneron antibody, for example, which is one of them, no longer had efficacy against Omicron, and the trial had to stop because it wasn't considered ethical to study this drug when the Omicron variant was becoming the dominant variant already in the US. But hopefully you're right, there'll be further either existing antibodies or new ones that will come out that will be used in that setting as well, sort of for post-exposure prophylaxis. So with that, so hopefully there will be a collaboration for us. I hope in the future. I'm really looking forward to it. I keep every day that somebody comes to you with a new clinical trial. My email is waiting and ready for the next one that you send along. I'm always willing, ready to participate. So with that, let me end in the last couple of minutes with a couple of your thoughts and overall sort of philosophy about where we are right now. It's interesting. It is Gordon just directly messaged me. Gordon's the executive director here, about any guesses as to when the peak is coming. And that was exactly what I was going to kind of answer right now, which is sort of to say, are we at the end of the beginning phase of COVID? In other words, are we heading from a pandemic into more of an endemic thing that we're going to have to learn how to live with in the next phase? Kind of what you alluded to before. Let's measure risk and go about and live our lives and just accept kind of what comes as we go from pandemic to hopefully an endemic with a less virulent strain. Or is this really the beginning of the end? Do you see this peak? When is this peak going to come and when it leaves? Because Omicron has been so infectious and so dominant so quickly, in its wake, when it does wane, are we finally going to be out of this pandemic? What are your best guesses? What do you think?
Yeah, well, I'm going to steal a line from my husband, which is, I think I left my crystal ball at home today. I really don't know. None of us do. I think, we can make some educated guesses. I think the mathematical models are predicting that our peak is soon. So I certainly am holding on to hope for that, because I would love to see things quiet down for everyone. As far as projecting into whether this is going to become endemic after Omicron, I think is more challenging. And I would say I've been humbled by COVID so many times, I'm a little bit wary to give you an answer. Many of us think and hope that that with increasing immunity in the population from vaccines and from infections, that this is going to move towards more of an endemic respiratory infection that comes and goes, similar to other ones that we see, without causing as much disruption as we're currently seeing. But whether this is the last one that's going to get us there, I think we don't know yet. But I would say that, getting the world vaccinated is a really important priority to getting us there. And I hope that happens and that people really take that more seriously than maybe they have over the past months. And
are you dining in restaurants now, or do you see yourself dining in restaurants in the future, near future, getting back to a normal life, going to movies?
Well, 2 full-time jobs and 2 elementary school kids don't allow you very much time to dine in restaurants, period. But we have not been dining indoors during the entire pandemic. We've been a little conservative that way. My family went out for our first outdoor meal, actually, to celebrate my children's full vaccination status. I would have taken them earlier, but, dining outside in San Francisco with 2 young kids seems less appealing to me than getting takeout. So it's less because of risk. I think being outdoors is quite safe and is something I'm comfortable with. But I personally wouldn't take my family to an indoor restaurant right now.
Yeah, we're the exact same in my family too. So you're no more conservative than we are. So Sarah, thank you so much for joining us today. I think my wife's going to chime in here to say a special thanks as well, but I really appreciate it. And on behalf of all of us here in the CSI community, and also I'm really looking forward to hopefully getting to collaborate with you and work with you on several of these projects in the future. It's a pleasure of mine, and I really do enjoy getting to work with you. So thank you very, very much.
Thanks so much. This was lovely. Thanks for having me.
I just want to add my
Hold on.
echoey huge thanks to both of you. In this really confusing and complicated time in our world, we have relied so much on each other, and what we've found here in our community, we look forward, Sarah, to welcoming you to the most beautiful synagogue in America here at Shereth Israel. You know, what we've found here in our community is that we've taken really excellent care of each other through this time, and we are much stronger for, not that I would wish this pandemic on us ever, but I think many positives have come out of this, and one of them is just a real sense of the value of community and the need for sharing everything from ideas and information and instructions, and also just virtual distant hugs. I mean, as we navigate this time and are very unsure about what to do next, a cup of tea on the back stairs sometimes is the best medicine, I think, for all of us, in trying to just navigate how we're gonna keep going forward. So having trusted friends and doctors and experts from within our larger community is so meaningful to us. We don't have to look too far for the best information that's out there. So thank you, Sarah and Jonathan, both of you, for having this conversation for us and with us to really help us understand what we know right now. So thanks to all of you for joining us, and we will be completely virtual at Congregation Shereth Israel this weekend. You're all invited to join us for services Friday night at 6 o'clock on Zoom, and for Torah study Shabbat morning at 9:15 on Zoom. And we hope, with our doctor's permission going forward soon, that we will be back together in our beautiful sanctuary. We'll keep you posted. So please keep watching your email and stay tuned, and keep in touch. Stay healthy, everybody. And thank you so much. Good night.
Thanks for having me. Take care.